So we're going to welcome the public to our meeting today as well. So this is the meeting of the Oxleas NHS Foundation Trust Board of Directors on Thursday, the 2nd of July 2020. So welcome everyone. Do we have any apologies for absence, Sally?
No.
For a minute, go through. I know colleagues have already given details of minor amendations and some less minor ones than that, but go through please for accuracy. Page 1, page 2, page 3, 4, 5, and 6. So Sally, matters arising on the health and safety. Just remind me what we're doing on that one.
This we've had preliminary discussions, and then we were going to bring it back to a board strategy away day when the agenda allows. But it has been discussed through the workforce committee.
Okay, thank you. On the ethics group, what's happening on that, Iffy, please?
So the ethics hasn't met since the last board, and what I plan to do is to propose to the executive later this month at our business exec meeting that we stand down the ethics group, but be prepared to bring it back on should we have a second wave or if a need arises. That's the plan.
Okay, thank you. On the as we go into the 136, Steve James, are you content with that so far?
I am, except I'd like to see what the Greenwich Directorate has done. So far, so good. And
Yemisi coming through to PQAC, you happy with the route of things coming through to you on that?
Yes, that's fine by me.
Are you happy to take it off as a matters arising, that there's a process in place that things are getting reported up?
I'm certainly seeing them reported up. Yes, I think I am. Please, so take it off the matters arising. It is being reported to the exec, and it's cropping up on our Tuesday morning meetings, and it's coming through obviously to PQAC. So Steve James, you content with that?
Yeah, I'm fine.
Okay, thank you. COVID risks, I might be doing things slightly out of order, but there was a discussion about wave 2 for COVID. Matthew, any thoughts on that, about given that in the light of Leicester, and I noticed that Medway's figures were quite high, and I noticed that East Kent's were quite high the other day.
Yes, and I mean at the minute, Andy, the numbers in London are remaining fairly well controlled. There's a lot of look at borough by borough figures, and there's a discussion later today the Regional Urgent Emergency Care Board in terms of how we would manage localised outbreaks within the region. So, for example, if you did have an outbreak in an area where there was an emergency department, would you want people travelling in and out of that area? Or conversely, what would you do if there was people from areas that were in lockdown and were needing to access healthcare? Because obviously healthcare environments remain a high-risk place for transmission. At the minute, though, I think things are, the key thing is getting reliable data on the spread of infections and the whole test and trace thing. So just now, I think the key thing is to be flexible and responsive and ready to step up when needed, rather than trying to predict the future a bit too much.
Okay, thank you. I'm just jumping ahead, and please, people jump in if you want to catch up on something. It's moving on towards the
Andy, could I make a quick comment about
community beds? Yeah, please. Yeah, please.
Just a quick one. Matthew, do you think we need a specific risk, documented risk around the second wave, just to show any mitigations that we have put in place should one occur nationally or locally?
I'll have a conversation with Ian and the exec about that. I mean, I suppose it is a risk. We do have clear business continuity plans and the goal structure in place, which is our mitigation. So we'll have that discussion about the risk and the mitigation, assess it, and take a decision whether it needs to come off the board assurance framework, or if, in light of the fact that we've got some pretty resilient structures, we think it's mitigated enough to not reach that threshold.
Okay, thanks.
Thank you.
Yeah, okay, thank you. Sally, you're saying I'm breaking up a bit. How's that now?
Yeah.
Yeah, okay. Right.
Yeah.
Okay, thank you. Just on 1876, around Eltham, Suzanne had raised the point that we're waiting for an SI. I do appreciate they might not be exactly the same point, but we were not content to reduce the risk at the moment on 1876 until the outcome of that particular SI, appreciating the fact that, as I say, they might not be entirely the same thing. Matthew, any comment on that?
Nothing much to add. I mean, I think the risk 1876 was predominantly about the additional services we were anticipating intermediate care having to offer. So had the first wave of COVID reached some of the earlier modelling, there was a view that services like Eltham and Meadowview would have to expand considerably to cope with both sicker patients than usual and also with additional community pressures as well. So that the risk was predominantly the impact of that, but I understand the associated concerns. So I think leave it there and we'll conclude the SI and then we can come back to it next time.
Okay, thank you. Steve, on 1877?
Yeah, just picking, thanks, Andy. Just picking up on the conversation, the point from Yemisi and the response from Matthew. I think 1877, which is on page 20, is quite a good place, certainly, to pick up the financial risk and costs involved in a second wave. So to insert something in the text there, I realise there will be clinical impacts as well, but I'm just on the financial point. And also on 1877, two other points we could build in there. One is it does touch on future NHS settlements from a financial perspective. And we already know that the capital control has changed, partly because it's now based on the ICS rather than everyone making independent decisions. So I think that needs to be built in there. And also the aspect from the 1st of June, we know that there's greater control over subsidiaries, but also in effect there's no facility at the moment through NHSE or I to get approval for any transactions through subsidiaries. And obviously that affects ourselves with Oxleas Property Partnership. So I think they're all aspects to 1877 that need to be just built in there. And it may very well, I suspect, involve an adjustment to the risk. It'll make it a higher risk. That's all.
Will that be dealt with through audit and risk? Was that ASRA? Would you make an adjustment to that?
Yeah, I think there's probably three committees at play, actually. The business will want to look at the financial risk aspects in conjunction with ASRA, and then, as you say, audit and risk, and also infrastructure from a perspective of capital and top implications. And then also, as I say, there's the clinical aspect as well, which would probably be a separate risk.
Sorry, Andy, could I just come in at this point? Just to say then, we should be shortly in the next 2 to 3 weeks getting some information in regards to the recovery period. So effectively the month 5 to month 12 settlement. And I would propose to make the changes once I've got that as well, because then we'll have something for the last 5 to 12 months of this year. And I can accommodate all of the adjustments that Steve said, going through those committees during that next cycle. So for the next board, we should have an updated set of risks.
Joe, do you want to come in on 1893, Legionella?
Yeah, just a small point. So this is the new risk around estates that aren't being used very often or have been vacated temporarily. I've no particular risk with the issue with the rating. It's just the gap in control that's set out is that the estates department may not be advised that the building is not being used. And the control is that the mitigation proposes that service directors inform head of facilities. I guess that just made me nervous that whether we also ought to have a proactive check that someone from estates periodically, maybe every month or whatever, would just run through and make sure that we do have a comprehensive list of those properties that we are worried about because of low use, etc., rather than waiting for service directors to tell us. I'm just nervous that with everything else going on, we just need a double check in there. As I said, I think the rating is fine, but we know in the past that we have had issues on certain sites. And this is one of those things that if you get it wrong, it's potentially catastrophic. So I just thought that we also, and I suspect it's probably being done anyway, but maybe we need to make it clear in the mitigations.
Hi, Andy, would you like me to answer that? We do it proactively. So we rely on services to let us know, but also the facilities managers are now getting out to sites on a regular basis, and we've got a list of those sites that are not being used. If they're not being used at all, then we are flushing. Where there's low usage, we're keeping in touch with the teams to make sure that we're aware of that, but I have assumed the water flow is adequate. But I take your point that it does need a systematic approach, and I think we've got that in place.
Might just be worth adding that to the risk register just to demonstrate that. Thanks, Rachel.
There's a question, is that you, Rachel, on 1471, or is that Rachel C?
It was me, Rachel C, rather than Rachel T. Now all right for me to raise it, Andy?
Oh, yes, yes, please.
Cool. So we've currently got a risk on the BAF, risk 1471, which relates to discrimination. And it's currently quite focused on discrimination from service users and carers and members of the public. I think in light of recent events and the focus on racism, I think we're hearing much more through the organisation from people who feel that there is scope for us to be improving our internal processes and approach in relation to discrimination and fairness. So I would be advocating in favour of us expanding that risk so that it explicitly includes issues of racism within the organisation, as well as from service users and carers. We've got a lot of work going on in this space, and I think we'll be able to include in there those mitigations, but I think it might be timely for us to expand the definition of that risk.
Does that go through the committee, or do you want to do that risk from here?
I was proposing to bring it to the Workforce Committee this month. I just wanted to highlight to the board.
Okay, that's fine. Yemisi?
Yes, I just wanted to raise the point, do we need a strategy risk? We've talked a lot about all the improvements that we've made during COVID, like the increased digitalisation, and whether we need a specific risk around the fact that if we do not adjust our strategy in light of COVID, we might be heading in the wrong direction. So just to take into account all the different organisational things that we have done and combine that in one risk. I couldn't quite see it evidenced in any of the current risks that we've got on the back.
Matthew?
Andy, we've got a plan to bring the latest on the strategy to the September board. And I think, throughout the COVID period, we've been very conscious to look at the strategy work we've done and to measure up how well that fitted with what we'd had to do during COVID. And I suppose one of the most heartening things about it is that the kinds of things we've had to do in COVID have very much aligned with what we talked about in the strategy, which was a big focus on workforce, on supporting workforce wellbeing, on making sure that we have services that are flexible and responsive to patient need and to staff need and so on. And I think it's probably strengthened the need for us to commit to some of those things that came through the sort of first phase of the development strategy. My suggestion would be that we have the September session and really get under the skin of this a bit and then see what people's views are once they've had the chance to hear about the development work we've been doing in the last couple of months. And if at that point we think it's a risk, but my view is that the organisation's been very responsive to tuning the strategy in line with the development through COVID, and if anything, it's accentuated the need for some of this. Rachel Clare might want to come in on this as well.
Thanks, Matthew. No, that covers it perfectly. Thank you.
Thanks, Matthew. Suzanne, you wanted to come in on 1877?
Yeah, sorry, Andy, I didn't manage to unmute myself quickly enough to follow Azra. It was just around to pull in Steve Dilworth's comments about the nature of this risk and issues around the ICS wanting to strategically determine capital expenditure. This isn't just a financial risk. I think this is very much about forward planning of the estates. And I think as chair of infrastructure, I will be going to Risk and Audit Committee to discuss the infrastructure risks, and it's something that I'm intending to raise there with Steve. And I think that these various risks shouldn't just all be bracketed under finance, and so I want to have a discussion with Steve at Risk and Audit about how to properly identify those risks and the mitigations that need to accompany them. And it's a conversation that I've already started with Rachel Evans about particularly how we deal with the kind of ICS having setting a total cap on capital expenditure.
Okay, Matthew, Azra, on that one.
Clarification I would say is it's not the ICS setting the control total, it's NHS EI, and then we as an ICS collectively should be managing that overarching control total. It may seem pedantic, but it's just saying whereabouts the control total is going to get issued out from, so it will be from the regulator.
Please sing out if I've missed anything on the BAF or the risk register. If not, because it's quite interesting trying to do it this way. If not, we'll go on to you, Matthew. Thank you.
Thanks, Andy. I'm not going to read out all the content. I'll assume people have had the time to do that. But I suppose if I just talk broadly, there's a summary in there of some of the changes we've been making to services. We're in a position where we are now starting to take decisions about where we've made wholesale changes, we carry on with that, where we need to rein some of that back in because the models that we've developed during COVID haven't been optimal in terms of the service that patients get from us. And actually in some areas where we've stopped doing things and changed fundamentally with the way we provide services and where actually the way we're doing things now is better and is offering a better patient experience and a better staff experience. So as part of this sort of strategy update in September, I think it'll be good to talk about the kind of spheres we've got into with some of this. And as you can see from the description there, mental health services, we do have a real range from the inpatient services where there's been very limited range for flexibility, but we've seen demand change. So, for example, the use of our intermediate care beds has been far lower than anticipated. We've done some really quite innovative work at places like Elton around the support we've given to people with neurological problems and other. In the inpatient mental health services, Ian will talk more about how we've been managing the bed pressures there, but there's been some really important and positive changes there in the way that we're managing capacity and flow. and how we're trying to support people. Our IAP services have changed to a wholesale embrace of digital. And I think those of us on the board know that we've been tentatively piloting digital IAP. We've now gone wholesale into that. I think that's one of those areas where we need to understand the range of experiences of patients and staff in terms of the different therapeutic modes we've worked, what's worked for people and what hasn't. And in some cases, we may be very keen that we get that certain groups of patients back into face-to-face services. And I know some services have been carefully triaging through that. So there's been a range of things happening there. There's a bit more detail in there. There's a lot more detail in the report. We do now have, although for some people, and judging by the state of the roads, there's a lot of people who are kind of going back to business as normal, but there's still a significant group of people in South East London who are in the shielded and vulnerable area. And we know both in terms of the risks to people from BAME backgrounds amongst NHS staff and service users, but also the long-term health impacts of severe mental illness, that some of the people who use our services are particularly vulnerable to the risks of COVID. So we are having to look differently at how we design our services, both in mental and community health, but also across the whole acute healthcare sphere, because we're now in a situation where actually there is both a risk of healthcare environments encouraging the spread of COVID, but there's also the changes that have been made to healthcare environments to cater for COVID, which means we have less space to see and assess people. And that creates a secondary consequential risk, because we know that if people are waiting for longer to be seen, or if there's less space to assess people, or the kind of assessment is different, that creates a secondary risk as well. So we're having to look at how particularly the people that are shielded and vulnerable get their support and service from us. And what that means continues to mean for those of our staff who deliver a lot of their care face-to-face in people's homes. There's a lot of dimensions to this. It's a very live discussion in the exec team. I mean, the next thing in the report was about use of technology, and it's not just in terms of how we deliver services, it's also how we work. And it's very noticeable that actually we, in common with all NHS and social care organisations, we spend considerable sums of money annually to fund the buildings infrastructure and the digital infrastructure that allows us to work as a health and social care system. And we've had some really interesting conversations in the last couple of weeks, including with some of our local authority partners, about how do we work together as integrated systems to think what are our requirements now for things like office space and meeting space, and what's the digital infrastructure that underpins that. And is there an opportunity for us as systems across, say, Greenwich or Bexley to say, well, look, if we are spending X million pounds on physical infrastructure, if we work together and make greater use of this kind of technology, how can we save some money there and reinvest it both in better infrastructure for those staff that have to work in patient settings, and improve digital infrastructure for those of us who work flexibly or work at home, and then how we look at the requirement for different kinds of physical space for the occasions when we do want to come together and work as groups and talk about the kind of things that work better in those forums. And I think, you know, we need to start thinking flexibly across digital and physical infrastructure about how we provide that across health and social care as we move into more integrated service delivery. And that again is something that we've been discussing at length within the exec team, and we'll come to the board with some further proposals in due course. And then the third issue that really to talk about is the impact of COVID on people from BAME communities. And what we've seen is that, and I've talked about this with this group before, it's not that there's any genetic predisposition to COVID-19 being more dangerous for people from BAME communities or backgrounds, but because of the prejudice and inequality and lack of opportunity that people from BAME communities face, they're more likely to be exposed to circumstances that increase the risk of the transfer of COVID. So that's more working in jobs where you're more exposed to people in close contact in confined spaces, and where you don't necessarily have the luxury of working from home or of deciding in your job to step back from face-to-face contact with members of the public. So what we've seen is that you like to think of pandemics as being relatively neutral in terms of how they affect people. They haven't been. In this case, this pandemic has disproportionately affected people who've suffered from lack of equality of opportunity in their lives and what comes with that. And there's been, and you know, there's a great graph in Inside Housing magazine that shows the COVID impact in areas of London where crowding and overcrowding and poor housing is greater. And I think actually that's a very clear evidence that actually societal infrastructure and inequality has led to disproportionate effect on people with BM backgrounds. And within the trust, we've now had a series of discussions with staff from a range of backgrounds about what we need to do to understand this, to assess risk, but also to create a broader conversation in the trust about how we understand difference. Because actually, if you look at Black Lives Matter, you look at our lived experience network, our LGBT network, our disability network, actually there are a range of differences within our workforce, within the people that we care for. And actually what we need to do is be a trust that is more open to conversations about difference and more understanding of difference, and where we increase education around this. And I spoke to a member of staff last week who very eloquently described the challenges they faced and said, and this isn't the case everywhere, but what this member of staff said to me is, I haven't encountered any racism at Oxleas, and they'd moved here from another trust actually for that reason. They said, I have encountered barriers because of a lack of understanding, and what we're trying to do in my team, this person explained, is get better at understanding each other's lived experience, whether that's to do with your race, whether it's to do with your sexual identity, whether it's to do with disparity in life opportunities related to poverty and where you grew up and the opportunities you had off the back of that. And I think this is a very important conversation for us to have as a trust. I think it's one that will take us a long time, and I think it's one that we, as a leadership team, at all levels of leadership within the organisation, really need to invest time in, because it's not an easy conversation. And Andy, you and I have had some, what I found really fascinating conversations about your experience in the police as a result of Stephen Lawrence's murder and the McPherson report. And I think the NHS has to be very careful that we move beyond a rush to say how terrible this has all been, and actually into something that looks like some really concrete action. We will win the trust and confidence of our staff and of our service users by demonstrating real measured change. But this is a problem that is decades and centuries in its genesis. It's important that we don't rush to superficial fixes, and that we take the time to understand the kind of deep cultural change that the organisation will require to find its way through this in the context of a wider NHS that also does have a problem with prejudice, racism and lack of opportunity. So that's it from me on the report, and happy to take questions about any of this, recognising I've just opened up a potentially 2-hour conversation with a lot of moving parts.
Dan.
Thank you very much, Matthew. And I wanted to very strongly endorse what you were saying about the health inequalities agenda from 2 perspectives. And one is how entrenched it is in different parts of the system, but that we nevertheless, as an NHS, have an opportunity to address some of the ways in which collectively those health inequalities are attended to. And I would really like to see Oxleas playing a very proactive part in engaging with our local communities around how we can work together as education providers, health providers, housing providers, and so on, because I think it has to be a very much a partnership piece of working. Purely from the perspective of of ourselves as a trust, and just focusing momentarily on our mental health provision, do you know what has happened to the patient and carers race equality framework that Simon Wesley proposed? Because my understanding was that the NHS was supposed to be developing it, and I suspect it's either fallen into the long grass or has been overtaken by COVID and forgotten about. But if there isn't going to be a national equality framework, and I mean, even if there is, it'll take ages to come down the line. I'd like to suggest that we develop one, quite possibly with our other partners in the South London Partnership, to get moving on this and not wait for the national system to tell us what to do.
Yeah, thanks, Suzanne. I don't know where that piece of work has gone. I think there's quite a lot of stuff that's been slightly put on the back burner through COVID. I would agree with you. We don't need to wait to be told nationally what's right to do here. I think there's a moral imperative to get this sorted quickly. Well, not as I say quickly, to get it sorted as a matter of urgency, but to do it properly. And I think Rachel and Claire Evans has been doing extensive work with our staff networks to understand this. And I think it was exactly the right kind of thing that we as a board should be championing.
Sorry, Andy, this is Ian. If I could just respond to Suzanne's first point. So we are actively engaged in conversations through in each of our boroughs through our local care partnership structures, and in Greenwich we are working alongside other agencies to organise initially a summit in Greenwich which engages the public in these conversations. So I'd be very happy, Suzanne, to have a conversation with you about that outside of the meeting. That would be helpful.
Thanks very much, Ian, and I'd be delighted to continue the conversation outside of the meeting. Thank you.
Thanks very much for that. Other questions for Matthew, please? There seems to be universal praise for your report, Matthew. Thanks very much indeed.
Thanks, Andy.
So we can move on to Ian, please. Ian Diamond.
Thank you very much, Andy. So I'm going to talk about three things. Initially, to talk about how we're continuing to manage our response as a trust to the pandemic. I'll then talk briefly about the dashboard that was in the pack, and then talk in a bit more detail about how the pandemic has impacted on waits for services. So in terms of our management, the management of our response to the pandemic, as colleagues will be aware, the NHS remains at level 4 alert. We have retained the incident control centre function centrally, but we have scaled this back, and many colleagues who have already returned to their substantive roles, or there is a plan for them to do so. We continue to have internal calls within the trust, and we also continue to produce a staff bulletin twice a week to keep colleagues informed. Pinewood is still being used as a PPE distribution hub, and we now have a delivery system in place to get PPE out to services. In terms of antibody testing, this continues to be rolled out throughout the trust, and the current programme is due to finish on the 10th of July. We anticipate by the 10th of July that we will have tested the majority of staff and contractors. Just to let the board know, as of yesterday, we had tested 2,808 staff. If there remain colleagues who want to be tested beyond the 10th of July, we will put in bespoke testing arrangements. And at the request of the ICS, we have been asked to put a form together for those colleagues who are declining the test, just so that we capture that. We also continue to produce a number of situation reports for NHS England, for both our internal trust services, but also the services we provide in prison. In terms of COVID-related staff absences, this continues to fall, and the same is true in terms of inpatients and our prison population. So as of the 30th of June, we actually had no inpatients who had been diagnosed with COVID-19, and we had 3 prisoners, all of whom were at Wandsworth. And just to reassure members, we continue to carry out antigen testing at the point of admission. I mean, just one last point on the kind of response to the pandemic. Colleagues have also already talked about the potential for a further surge in cases. I think that's very much in our minds, and and in terms of not scaling down completely the ICC because of that possibility. And certainly within the ICS, there is a lot of discussion about how we document and manage any potential future outbreaks of the disease. So that's all I was going to say about COVID. I don't know if there are any questions before I move on to the performance data. Nope. Okay. So in terms of the performance board. What has been shared today is the latest iteration of the dashboard that we have been using throughout the pandemic. There has been a discussion that has taken place at the Performance and Quality Assurance Committee regarding retaining this format in the future, because I think there is a sense that as a format it works very well. But we will be adding back in other key metrics, for example, those that were on the single oversight framework. And there is a plan to engage with non-exec colleagues to shape this up further. So I anticipate that by the next board meeting, we will have a kind of more definitive version of the dashboard. In terms of the data that's included in the dashboard, the one thing I really wanted to mention was our bed position. So as Matthew's already alluded to, in terms of our intermediate care beds, we continue to see quite a lot of capacity there. And in terms of our mental health beds, despite the fact that quite a lot of demand has come back in the last month or so, we are seeing a very positive bed position. So we continue to have 2 wards closed, but every day over the last few weeks, we have gone into the evening with capacity, and the legacy UEA placements has continued to reduce to the point as of yesterday we had 4 people in private placements. So I think this is a testament to the 3 directorates working extremely well together. There's been excellent engagement, I think, from both local management and clinicians. And I think the leadership of Francis at Zinku in terms of the kind of central bed management function has been fantastic, actually. So I think we're in a very strong position. We've had another week of no 136 breaches, and also no, in terms of our ED 12-hour breaches, we've had none in the local hospitals. So that's what I was going to say about the dashboard. And in terms of the operational report, what I asked the directorates to do, and hopefully is reflected in the report, is just to give a summary from each of them regarding what the current status is in terms of service delivery. And Matthew's already alluded to the fact that this will be the kind of future shape of services is something that we will continue to focus on throughout the summer to ensure that we retain the gains that we've achieved through the pandemic, but also learn some lessons about things that perhaps have not been so good for patients and their families. And my sense is that in the future, we will see a kind of mixed model of service delivery, which retains some of the virtual working, but starts to bring back in some of the face-to-face work. One of the kind of aspects of operations which has inevitably been affected by the pandemic has been waits for services. Colleagues will be aware through the various directorate operational reviews that there were waits for some services already, but I thought it would be helpful for board colleagues just to kind of get a sense of how the pandemic has affected waiting times and access targets, and just to give an early sense of what we're trying to do to mitigate the risks of waits escalating further. So in most cases, in most services, waiting times have been impacted by the pandemic, either because services have ceased due to either the us invoking the trust business continuity plans, or because services were asked to follow national guidance. So colleagues will be aware that there was national guidance published for community health services for both adults and children's. Because of that, we have seen service prioritisation, and part closure in some cases, and staff redeployment. And also we've had services that couldn't be adapted to the context that lockdown created around social distancing. And I think that the last kind of dimension which has impacted on weights is actually patient behaviour. So understandably, a number of the people that we work with, particularly those who have an underlying vulnerable health conditions, were fearful about accessing services in the way that they had previously, and that has led to a number of appointments being cancelled. So what that means is that in some service lines and in some particular services, this has left us with some significant challenges, particularly where there was an existing problem pre-COVID. And I would point out that some of the biggest challenges are around our Bexley Neuro service, our memory services, specialist assessments within children and young people, particularly ASD and ADHD. And then also the existing CAMS weights have been exacerbated by the pandemic. Audiology, which sits within CYP, has yet to recommence, and as the narrative in the report says, we're just working out how we bring that back online. Conversely, in prisons, waiting times for GPs has improved slightly. So there's quite a lot to do, and I just wanted to reassure the board that through our quarterly operational performance reviews, which non-exec colleagues do join, we will be monitoring the progress of directorates to kind of reduce those weights over the next few months. So I'm going to stop there, and obviously happy to take any questions.
Thanks very much, Ian. Joe had a question on use of technology, and if Joe can ask a question, and then Alison wants to come in on that one as well. So Joe first, please.
Contact type sheets are showing that the replacement for face-to-face has largely been via telephone. So the green line, is moving in the right direction, but slowly. But I'd be interested to see what Alison says.
I mean, just before I bring Alison in, Joe, I think we are, as colleagues know, we are surveying service users at the moment to kind of, and one of the questions we're asking them is around how they found engaging with us in a kind of virtual format, and we will tease that out. But I think the other significant point, which I think I raised at the Council of Governors, is the fact that in terms of the people we're working with, there is, it's a diverse group of people, and there are pockets of deprivation, and within those kind of deprived communities, there is this concept of digital poverty, and we need to kind of test out whether patients and their families have the access to technology that perhaps we might assume. So I think there's something for us to do internally, but also it's just really testing out with service users about what they have in their own homes as well. Sorry, Alison, do you want to come in?
Yes, thanks. I mean, I agree with everything you say, Ian. However, I do think there are some members of the public who are happy to engage with this in this way. In terms of numbers, I think there's partly it is a reporting issue, in the sense that we know that some staff will be recording a telephone appointment because they're using a telephone to do a face-to-face appointment. So I think from speaking particularly with CAM staff, they thought that some of the data perhaps was being recorded incorrectly. So that's an area we need to work on. But the reality is video is a small part of what we are doing, how we are conducting these appointments at the moment. There's some really good examples, as Matthew mentioned earlier, in IAP services. And I think in June we nearly got to 1,000 appointments for IAP services being done by video. But there's clearly more that we can be done. And in some of the areas where we're seeing the bigger weights, so memory services and in IAP services, in ASD services, I know that both those teams have plans to put in place Attend Anywhere or Microsoft Teams appointments. So it'll be interesting to see the progress of that in the coming month or two and see what impact that has on the wait times. And then finally, just to pick up on the point that Matthew mentioned around recovery, I think we really do need to be considering how we embed digital in all of our pathways so that we have a mixed offering. So for patients who are nervous about coming into services or where we have less space to be able to provide those services because of COVID, we have a digital offering alongside a face-to-face offering for patients. So I think it's a work in progress, and I think over time we'll see that steadily increase.
Thanks, Alison. Stephen Deworth, followed by Steve James, please.
Thanks, Andy. Hello, Ian. And first of all, congratulations. I mean, your point on waiting lists is well taken, but equally, all the teams have performed extraordinarily well in the recent months. Couple of observations first, then the questions. Memory service at Bromley. Appreciate the problems about the lack of scanning and the diagnostic appointment. But it just seems to me, actually, that what you're doing there, notwithstanding the challenge, is actually the right decision to get on with the service and see people as quickly as they are. Also, on page 42 about Bromley PCP, I thought that was actually a good example of the benefit, actually, of what can happen over COVID. The fact that they've been able to cleanse a lot of their waiting lists and caseloads. So we shouldn't forget there are some benefits during these times. Page 48, you refer to ISIS and the lack of GP sessions, but I understand from communications with Keith that that's down to commissioning, and at the next commissioning round, that will probably be adjusted upwards so that there will be more GP sessions available. So hopefully you confirm that's the case. Two questions. You refer to the waiting list on neuros, and I know it's over 32%, or waiting over 18 weeks, but there is some recruitment. It'd be useful to get your view on how quickly you think, with the recruitment and the staff getting bedded in, that will come down to a realistic figure. That's question one. And then question two, which is more of a general nature. Obviously, the pandemic has brought in a management and operational style throughout the organisation, and also will be anticipating a possible second wave. I'd just be interested in your views about what are the challenges, in fact, of people adjusting to the new normal time, because obviously the sort of rapid decision making that we've been doing in the last couple of months may not apply. So I'd be interested in your thoughts on what challenges that gives you on the operational side, and what adjustments you can make to help staff deal with those challenges, because that'll be a different world to what we've ever experienced before.
Thanks, Steve. So in terms of the specific question around neuro, I mean, I'm confident that we will make inroads in terms of the waiting list. I mean, colleagues will remember that we had a situation last year where recruitment to Bexley Neuro was looking quite negative, and then we were able to recruit quite quickly. So I think as long as we get the staff into post, then I think I'm fairly positive. In terms of the second question, I think it's really, really interesting. I think all healthcare providers are feeling this at the moment. We're in a slightly liminal space at the moment, where I think there have been benefits in terms of the kind of more controlling central command type structure. It has it's meant that we've made decisions quickly. But I think what I'm noticing is that within the organisation, people are tired and they're exhausted, and they're looking, as we all are, I suppose, to the kind of ease of lockdown as being a positive thing. My worry, I suppose, is that that messages start to get lost about things, simple things like social distancing, use of PPE, etc. So I think that's one of the reasons. That's a very practical example of why I think we need to keep the central command structure so that we can get messages out quickly to people. But I think there's a lot of questions still around about what the future model would look like. And I think that's why Matthew has already said that it's important that we think about that quite carefully before we kind of rush into bringing things back as they were before, or at least we have a kind of a more thoughtful process around that. So I anticipate that it's going to take the rest of the summer really to kind of get a sense of what that future service model will look like. So I hope that's helpful. I kind of answered the question partly anyway.
Thanks, Ian. Steve James?
Thank you. Yeah, no, it was partly one of those is following up what Steve was talking about on the Bromley PCP. I was really struck that it went from 524 to 105. So something was going on before or something's going on now. And I wondered whether or not, I'm sure we are, but are we doing that sort of process in other teams? Because the board discussed a number of times people's caseloads being enormous. Now, that might have been that the people's caseloads have people on it who shouldn't be there, or so I'm interested. Do we anticipate that sort of huge reduction elsewhere? And the other one was a very small question, which was about the length of time people have to wait for assessments around people learning disabilities and challenging behaviour. If you have to wait months, sometimes things can get out of hand. So is there a mechanism in extreme urgent situations where someone can get an assessment quicker than months?
Yeah, so in terms of the first point, Steve, PCP is obviously the front door into our mental health services, and through the operational reviews pre-COVID, we'd identified that there was an issue in Bromley, and the directorate were focused on that. Simply, what's happened is that there's a new manager, there's changes to process, and then with the pandemic, there's been a reduction in referrals. So the combination of all those factors has meant that there's kind of been a drop in the number of people waiting and the time that they've been waiting for. I mean, we do share lessons from one directorate with another, and certainly around PCP, there's been quite a lot of sharing of practice between certainly between Greenwich and Bromley. So yes, that does happen. In terms of ALD and challenging behaviour, there is that facility, and I think that's what ALD, the report is showing, is that that we are trying to think of ways to kind of reduce the waits that people have had, and it will be a focus over the next few weeks. As the kind of report shows, sometimes people aren't waiting very long.
You could go out, right?
So it is kind of our response is based upon the kind of individuals presenting. I think where we need to get to is to try average waiting time down as far as possible, so that you don't have these kind of variations which the report shows.
Steve, on that. Yeah, thank you, Ian. Ian, back to you.
No, that's me done, I think, isn't it?
Yeah, I think so. I just wonder if you had anything else to add at all. If not, thanks very much indeed. A really, really good comprehensive report. Some really impressive stats there. So thanks very much. So we move on to Jane, please, in infection prevention control.
Thank you very much. NHS England have produced this fraud assurance framework for infection prevention control, And it's been really helpful because it's allowed us to assess ourselves against all of the plethora of guidance and documentation that has come out on a regular basis throughout COVID. The document has 10 domains, which I have listed in the paper. And where we've identified that we have needed some mitigations, we have put these in place. So, for example, we have increased the cleaning from twice a day by making sure that staff actually do this themselves, so that they're regularly cleaning their IT equipment, wiping down and making sure that everything is absolutely tip-top, rather than waiting for cleaners to come in twice a day. And this is working well. We recommend the unannounced audits, infection control audits, recently. And these are really important because, as Ian has alluded to, there is a risk that people could become slightly relaxed around PPE as we go into lockdown. I'm pleased to say that the audit that was carried out on Danson ward yesterday and Elton community beds did demonstrate that there was good compliance and people were using their PPE. Messaging to reinforce areas. Another area of mitigation was Queen Mary's. They had hand dryers in the public toilets. These have all been secured and taken out of use, and hand towels are now in place there. And there was discussions regularly throughout the pandemic to date about whether we needed designated COVID wards. And as an executive, we felt our estate was so good that we've been able to secure areas that are isolated within each of the wards. So we haven't required this, and we'll keep that under review at the moment. We continue to review staffing, and we're doing this at the moment in the context of the urgent, which is a risk-managed pathway, which all our admissions follow, and what's also defined as an elective or a protected pathway. This is where there's more planning around people coming into the wards, for example, Atlas House or Barefoot Lodge or Oak Tree Lodge. Should we decide that they are going to follow a more elective pathway, and we'll plan those admissions with testing people before they come in, then we'll probably be making recommendations about making sure that they have a regular staff there and staff don't move around to other areas of the trust. At the moment, that's working well, so we think that's well mitigated. So far, I think we can say that we have good compliance with the BAF for IPC following our assessment. We've particularly focused on providing up-to-date information for our visitors and our service users, and making sure that service users particularly have access to sinks in their rooms, and that this is discussed in community meetings every day and supported and reinforced. And we've also identified that it would be helpful where we are tenants using our properties, such as at Queen Mary's, Sidcup, that we look at what they've put in terms of their IPC BAFs where they're using our sites, just to make sure that all of the interdependencies are covered. So we'll be requesting those. And finally, I'd like to take the opportunity to thank our infection control nurses, Helen Nichols and Emma Lewis, because as you'll see from the documentation, this is a huge amount of work that the two of them have been doing non-stop. And I know they've had support, fantastic support from estates and facilities, but they've worked tirelessly to make sure that we're compliant with everything we need to do for infection prevention and control. Thank you.
Pass the boards thanks to your staff for some tremendously good work and huge amount they've got through. So thanks very much for that. I know Suzanne raised a number of issues which answered. Are there any other issues for Jane on this, please? If not, thanks again, not only for yours, but also to Rachel's staff for their support to your team as well. If we're content, colleagues, we'll move on to the serious incident inquiry, and Michael Whitney, please.
Thank you, Andy. I hope colleagues can hear me all right. This is a report on an investigation that we did recently that we just really finished, very recently actually, of an incident that occurred in February, the very sad circumstances of Mr. MD, who was found unresponsive with a ligature around his neck in a communal bathroom on Scadbury Ward in Green Park's house. Excuse me. This is particularly sad because we had a very similar incident probably about a year earlier in Oxleas' house. So this was the second rather similar incident, which I also chaired previously. I'll take you through very briefly the highlight information in relation to the inquiry. The detailed report is in the pack for you to read. It is quite a lot of detail. So towards the end, I'd be very happy to take any questions. And I was very well supported on the panel with Suzanne, who obviously would be, I'm sure, happy to offer comment as well as we go along. And Sue Sauter, who I see is on the call as well. And I'm sure if Sue's got a view, she might want to contribute towards the end as I go through it as well. So very briefly, just to say that Mr. MD was a 69-year-old married man who had been admitted to the ward at Scadbury following an arrest. He had committed a sexual offence and he was awaiting trial. This was the second episode of care that he'd been provided for in Oxleas. The previous event had been about 10 years before. So he had a gap of 10 years where he had remained extremely well and had not been in touch with our services at all until the most recent event, which started again around November 2018. He was admitted ultimately to the ward and stayed with us on Scadbury until from about November, December 2018 until he died in February 2020. The terms of reference were particularly geared at looking at the most recent episode of care, in particular his stay on Scadbury Ward, and those are detailed there for you in the front sheet for you to review. So I won't necessarily go through all of those in detail. Just to say, I did meet with a family yesterday again, and fed back to them the result and the outcome of the inquiry, and their questions and the things that they raised, which we did take account of in the investigation, were as far as they were concerned, well addressed, which you'll see is one of the terms of reference. I think I just go very briefly through the recommendations. They are quite complex, and in order to get a fuller understanding of the recommendations, I think it's really important to read the detail of the report, but these are the sort of high-level highlights of the recommendations, and there were 5 in total. The first relates to the patient's engagement in psychological treatment. In this circumstance, Mr. MD was indeed offered psychological treatment, but he preferred not to engage, despite repeated attempts to engage him. But the panel were left with a view that that psychological treatment, although being regarded as a central and important feature of his treatment, wasn't given the same level of encouragement as any other aspect of treatment is given within the context of the treatment program within the ward. And Mr. MD's lack of engagement was not highlighted, not discussed, and it wasn't challenged. And we felt there was a missed opportunity there, particularly because of his offending behavior. We felt that about which he was deeply ashamed. We felt that he could have had made good use of psychological treatment in order to understand that better. And we felt that was a missed opportunity. The other bit about that is that we feel the panel felt that if a patient is declining an aspect of treatment while on as an informal patient on the ward, the question should surely arise in the minds of the staff about the patient's consent to being in treatment on the ward. If a patient, for example, decided to not take their medication, for example, or as in this case, he had declined to take up the offer of ECT, great efforts were made to try and engage him to ensure that he, that was seriously considered. Whereas with psychological treatment, somehow the same efforts weren't made, and we feel that that really does need to be addressed. The second recommendation relates also to the psychological treatment offered, but also more broadly to the experience of the staff within the ward. In this instance, as I said, Mr. MD had committed a sexual offence, and our view was that the ward staff weren't particularly skilled at dealing with this sort of presentation. And the psychologist actually had recognized that and sought additional advice and support from colleagues at the Bracton. However, she was discouraged from pursuing additional support there by her supervisor at the time, partly because she just didn't have the time available to do so. And we felt that it was really important that where patients present with unusual presentations, that the ward staff be offered the opportunity to make sure that they take full advantage of any additional support that they need and any learning that they need to support them in delivering the care for the patient. The third recommendation, which actually links with the first two, is that the psychology time on the ward is very limited. The psychologist told the panel that she's available on the ward only for a day and a half. There are 22 patients on the ward usually, and she's unable to offer individual treatment and tends to offer only support to the staff about patients rather than seeing and treating patients directly, simply because she doesn't have the time. And that was, in fact, as I mentioned in relation to the second recommendation, that's why she was discouraged from seeking additional support from the Bracton colleagues, because it was felt that it would take too much of her time. So we make a very clear recommendation that the amount of time that the psychologist is on the ward probably should be considered and potentially increased. Recommendation 4 relates to the environment and the assessment of the ligature risks on the ward. As colleagues will know, a particular tool called the Manchester tool is used to assess the level of risk of the environment and the patients within the environment. It's a complex process, and the detail of which is in the report. But in essence, patients who are admitted to the ward were scored at a lower score, and the view was that was not right. That patients who are admitted to the ward should be scored at a higher score, because by the very nature of them being admitted, the view is that they are at greater risk. So my understanding is that has already been adjusted, that a review of scores across the older people services has already been done. And then the final point relates to the support network engagement tool. Colleagues won't be surprised to hear that the family felt that they weren't as engaged in the treatment as they would have liked. They, of course, were invited on occasion to attend ward rounds, and there were various phone calls made to the family and by the family to the ward. But the family were really frustrated that they felt as though the ward staff hadn't recorded clearly who was to be involved in the care and at what point. And the support network engagement tool really does provide the opportunity for staff to actually record that information and then follow up on it. And in this instance, the support network engagement tool wasn't completed. So we make a very clear and straightforward recommendation about that. as I say, there's a lot more detail in the actual report, in the body of the report. I know Ian is going to talk about the action plan. Before Ian does that in a few minutes, I just wanted to say that I did apologise to the Service Director, Lorraine Regan, that we've given colleagues very limited time because of the way we've had to rush forward with bringing the report to the board meeting here. Otherwise, we would have had to delay it till September. So colleagues within the Directorate haven't had an adequate amount of time to address the action plan as much as they would have liked. And that's partly also because we paused the investigation for a period of time due to COVID. So everything got squeezed both at the front end and in fact by bringing it forward to the board today. So I just wanted to make that clear. Suzanne, I'm not sure if you particularly wanted to add a comment or think something that I might have missed.
There's nothing I want to add at the moment, Michael, but I'm very open to responding to any questions from colleagues if there's anything they'd like to raise.
Amlan, you've got a question?
Yeah, just quickly, I was really interested in your reflections, I guess both Suzanne and Michael, on the 6th term of reference, which from an organisational perspective, I think is really, really important, which is that learning from previous inquiries. And I noticed the term of reference talks specifically about how well those lessons were disseminated across the Directorate. But in many ways, that would be step number one. And really the key is whether the evidence that those lessons were not just disseminated, but evidence that they were implemented is the key thing. And I wonder what your reflections were on that when you went through this detailed report.
Thanks, Amlan. Colleagues on the ward, on Scadbury ward, were certainly aware of the incident that had happened a little less than a year before on Shepherd Lee's ward at Oxleas House. What they had more trouble doing was linking the incident and the outcome of the incident with the various things that had subsequently taken place. So, for example, one of the recommendations of the Shepherd Lee's incident was that staff, we had particular concerns in that incident around the resus that had been conducted. So one of the outcomes was that staff would be offered spontaneous drop the dummy, so-called drop the dummy opportunities to do some resus training. Staff on Scadbury ward said that, well, some of them at least said that they had done that. We had concerns about not all of them had done it yet. That's partly because of shift changes and so on, but most of them had been engaged in some drop the dummy exercises, but they had trouble linking the reason that they were doing more of those exercises with the event at Shepherd Lee's. So it was that sort of level of subtlety that was sort of missing. The other example was, for example, in the Shepherd Lee's incident, we made a recommendation about when there's a threat to life in one of the units, the tannoy system should be used to call all the medical doctors in the building to the incident to try and address the problem when the alarm is sounding. And in fact, what happened on at the Scadbury incident is that the tannoy was not used as we would have expected. And in this instance, it would not have made a difference in that it happened on a weekend evening, Saturday evening around 6:30. So the only doctor in the building was the junior doctor, who was called immediately anyway, so that it wouldn't have made a difference, but the principle was the same. So I think that is a real challenge for us to think about how we disseminate the learning and making sure that people within service lines understand the outcomes of these investigations.
Can I just add an additional comment to that? I'm glad you've raised this, Amnan, because I think it's a weakness across the NHS that there's a tendency for action plans to be implemented in the area where an incident happened, rather than for action plans then to encourage inquiry across a number of different parts of an organisation to say, well, to what extent would we see similar risks in our area? It's something that, because I'm engaged with Vikki Ellis in doing a board visit to the quality team, she and I have had a discussion about the effectiveness of learning from incidents, and it's something that I believe that she's going to be bringing forward a new, proposed new quality management framework in due course, and that will endeavour to ensure that these kinds of lessons are better understood, particularly across service lines, and that there's a proactive approach to understanding from other parts of the organisation what the risks were that precipitated an incident and whether those risks are also sitting in other service areas.
Michael, have you finished before we move on to Ian?
Yes, thank you, Andy. I don't think there's anything further to add at this time.
Thanks very much indeed, Michael. Ian?
Before I comment on the action plan, I think Jane just wanted to comment on the resus.
I think the subtleties about learning from incidents is really difficult, particularly when it's something as challenging as resuscitating somebody, and the experience of a resuscitation, which some of our staff only ever experience maybe once in their entire careers. So whilst the history of how things have happened may become lost, what we did do in response to the incident last year was to put in place an absolutely outstanding resus officer, Nick Stacey, and she has been going around to all of the units and reinforcing the basic training that they get for their statutory mandatory training and actually making it real. So she's been sitting down in small groups of staff, and we've carried this on through social distancing, and I've also participated in doing things like helping people to familiarise themselves with what's in their resuscitation bag, identifying the equipment, playing with it, learning how to use it, and actually talking about their experiences of resuscitation. And this has proved really, really helpful. We're getting fantastic feedback back from teams. And the key learning for us organisationally was people didn't have the confidence or the competence to carry out resuscitation when they were only trained every couple of years and they never came across it. So drop the dummy sessions have been invaluable, but having the resus officer and everything that she's doing and building that level of confidence within small teams who will be resuscitating together has been invaluable. So I didn't want people to think that this was an issue that hadn't been addressed or we weren't doing ongoing work about. Certainly from the issue last year at Oxleas House, so much has happened and people are definitely feeling better.
Thanks very much, Jane. Thank you.
Okay.
Ian.
Yeah, thank you. So as Michael has already said, because of the timing of the report, it has been difficult for the Directorate to put together a written action plan. The team themselves were only, the feedback to the team only took place yesterday. So what I'm just going to quickly run through are some initial thoughts from the Directorate management team. And what I was going to suggest, I haven't discussed this with colleagues, is perhaps that I bring the action plan back through PQAC. Just mindful of the fact that otherwise it's going to be a couple of months before the next board. But just some initial thoughts around the action plan. There's obviously two recommendations that relate to the provision of psychological therapies. One of the recommendations is around the actual resource that's available to the ward. One point just to kind of brief colleagues on is the fact that as well as the 1.5 days of qualified psychology time, there is also 1.5 days of an assistant. That post was vacant when the incident took place. The post has been recruited to, post holder started in March, but has unfortunately been shielding since then. So I think the Directorate want to kind of review the need for extra resource once that post holder is in place and up and running. In terms of the kind of general point about the importance of that's given to psychological therapies within the ward, hopefully colleagues will remember that we do have something called a MDT ward round template, and the idea is that that is completed by all members of the multidisciplinary team in advance of ward discussions, and that really is an opportunity for a review of people's engagement. And I think Lorraine is very keen that we make sure that that is running properly. Michael's mentioned about the review of the ward ligature audits. We just need to make sure that they are happening. I mean, following the incident on Shepherd Lees, it is now in the capital programme to review and make changes to the kind of environment in our old people's wards. And in a moment, I'll ask Rachel just to comment on the timescale for that. And then the last point, which is around the completion of the SNET and also access to training around particular kind of issues to do with sexual offending. I think really what needs to take place is a training session within not only within this service, but to make sure that we offer the opportunity for colleagues across older people services to have access to training for this particular issue. Rachel, did you want to comment on the environment?
Yeah. We've made the changes to the policy that have been agreed with the older people's service teams and changed the standards of equipment that we use in those facilities. And the piece of work to install those in Shepherd Lees and Scadbury is being specified at the moment, and then we'll go forward through the two different PFI processes for Oxleas House and Green Parks House. That is likely to be the thing that will determine the timescale, unfortunately.
Rachel, can't we lean on them? I know it's difficult with PFI, but if these are, pretty vital things to be done, we wouldn't be explaining to a coroner later on, why the delays were.
Yeah, we can and we do, and any support that anyone can offer us to do that, I will gratefully accept. But maybe we can talk about it outside this meeting.
Yeah, absolutely. I mean, I'm very happy to help in any way I can. I just keep thinking that they could be in the dock alongside us if they are obstructing us trying to put something in which is thought vital to prevent death. So I'm very happy to help at any stage.
Thank you.
Iffy, yeah, I mean, you made some interesting points on the chat there. And this is not a new issue, is it? In the sense of how do we generalize these lessons from different inquiries that we've looked at over the years? Sometimes recommendations overlap. There's a multiplicity of them, perhaps. And I wondered about how do we synthesize these things into real hard-nosed specifics that we can spread across to the appropriate parts of the trust. Because sometimes these recommendations just look a bit too general, and we know from our own experience going back for those difficult days of a few years ago at Green Parks House, where the very staff involved were unaware of what we'd actually recommended. I know that's changed a lot now. And then Yemisi's raised a point about embedded learning. I had some concerns about embedded learning a while ago, that you couldn't necessarily know that the staff involved had been to the embedded learning, and you couldn't always be sure that what we wanted was being taught at or being discussed at the embedded learning. Any thoughts, Iffy?
Like I said in the chat, one of the key challenges is often not being able to identify root causes, which if we were successful at doing so, would then enable us to systematically address those across the organization. And I sometimes worry that if we have a load of recommendations, it then becomes difficult for our staff to carry all of those along. It seems that we need to continue to work on this, and in particular, seek to identify the really critical things. So one of the things I put in there was whether as an organization we have a real appetite for increasing availability of other members of the MDT, psychology being one, rather than tinker around the edges, because that then means that you have a full and proper MDT. This is not the first time it's come up as an SI, but each time there is something and we just say, well, this is the action, and then we'll go on to the next and the next. We don't quite go right down to the bottom of the problem, say, right, let's fix it this way. So I think that's going to need a bit more work. From the staff point of view, quite apart from having lots of things to bear in mind, they sometimes struggle to see the relevance of actions in one place to where they are. I think we've come a long way in improving that, because staff will then say, oh, but that doesn't apply to us, that doesn't apply to us. And before you know it, they lose sight of the broader message, So we have improved on that, but I think we need to do some more work. Right across the NHS, as Susan and Amlan and others have said, this continues. This is an area where we continue to struggle to improve. But I think that there's room, certainly in Oxleas, to do this better.
Ian, I don't know if you've got any thoughts on this, because you're the one that I get sort of, I was going to say bombarded, but you get lots of these different recommendations come at you. Yeah. And I just wondered, is there a way of sort of synthesizing them, or I'm fearful of putting yet another process into this, but I did wonder about sort of capturing these and, not necessarily rejecting, but sometimes refining them, and with the agreement of those doing the inquiry, that's with or through PQAC or whatever, that you can actually come up with things that we can drive home without getting buried by lots and lots of different recommendations.
Yeah, no, I think some really good points made. I think it is difficult to make recommendations sometimes. Personally, I always try and resist the temptation to put the word review in. I think generally either something hasn't been done and you've got to do it, or we hadn't thought of something and we need to do it. And I think there is probably something for us collectively to think about how we write recommendations so that, as you say, the people, generally directorates who are writing the actions, can come up with some specifics. I think we have in the past tried to, where we've had kind of repeated themes, we have grouped them together. So I think somebody mentioned before when we had a situation at Green Parks House several years ago when we had a number of incidents, we did simply just group actions together and then have a really concerted focus on driving those through. I think a further conversation at PQAC would be welcome. I think it's something that we do have to get right if we're really going to measure that what we're doing is effective in response to incidents. I think Jane would like to come in.
I think I agree with all those points that both Vikki and Ian have raised. It's incredibly difficult to extrapolate the thematic learning across not just the service line, but even the entire organisation. What we've been trying to look at creatively within the patient safety group, and an arm of that is the serious incident performance group, is how we're going back and looking at the themes that have been merged. We're sharing these through the forums, such as the Acute Care Forum or the Older People's Mental Health Forum, but we're looking at ways that we can actually engage teams through, say, the Ward Managers Forum as well to share the learning. And when we go back and we pull out the themes, they tend to be very things that wouldn't surprise you, things that we've been battling with for a long time, such as involving families and carers in the support network, the risk assessments, the quality of CPA, or the care planning approach, or the resuscitation. And what we're trying to do is cluster some of these themes and learning together so that it doesn't become the story of one particular incident, and then identify all of the different innovations that have come together to try to address this, look at what's working, look at how practice has changed, and then look at the sustainability of that. But the other thing that we're really mindful of is we tend to focus on the negatives. We tend to focus on the what went wrong, what have we got to change, and what have we got to learn. But there's a whole wealth of really notable good practice which demonstrates where learning has happened and where practice has changed and where people did go the extra mile and do some pretty outstanding things, which if we hadn't have done the investigations, we wouldn't have picked up. So we would welcome further discussions at PQAC, and I would personally welcome anybody who would like to attend any of the patient safety groups or SI groups to explore this further with the safety leads within the directorates and across the organisation. I think we could have some really valuable conversations.
Thanks very much, Jane. It's really helpful. Suzanne, did you add anything to that?
Well, it's just a very quick thing. And I'm conscious that we've had a lot to deal with COVID, and now also wanting to take on the kind of health inequalities agenda. But there is an opportunity here in that the NHS was planning to pilot a new serious incident framework earlier on this year. The pilots haven't gone ahead because of COVID, but actually I think that there's huge merit to moving away from some of the ways in which we've worked in the past on serious incident investigations. And one of the areas, to echo what Jane was just saying, is around being able to recognise where there's good practice, and to learn from that as much as learning from poor practice, which is what we tend to focus on. We're very good at focusing on learning from failure and not learning from things that go well. But also to kind of echo one of the challenges that we face as an organisation. Colleagues may know that I sit on the advisory panel of the Healthcare Safety Investigation Branch. And fascinatingly, they are running into very, very similar problems as we find ourselves encountering in trusts, in terms of trying to develop recommendations that really make a difference. So for one, I would like to accept Jane's invitation to join some of those patient safety group discussions and to offer some of the expertise that I might be able to share as we go forward.
Thanks, Suzanne. I think that'd be really valuable. There's been a couple of points about psychology input. I suppose back to you, Michael, really, about, have you seen the comments on the chat?
Yes, I have. Thank you, Andy. I mean, I think there's a lot of detail there and all sorts of interesting ideas that Matthew's proposed around other people other than psychology, of course, and OT. So I think those are all very interesting ideas. We weren't aware that there was an assistant psychologist, for example, on the ward. That didn't come up at all. The fact of the matter is that the post was vacant, so perhaps that's why it didn't come up. But frankly, a day and a half for 22 patients of psychology is probably not enough. And so we, in terms of writing the recommendations, I appreciate the richness of the conversation. I don't mean to sort of go on now about that, but in terms of the recommendations, it is a challenge for us sitting where we are to make specific sort of Stalinist views on what should happen within a ward. So all we can say is, in terms of from where we see, from where we're sitting, what we see is there's probably not enough psychology. It's up to the directorate then to review that. So it's a difficult balance to get right. But I sort of take on board the idea about perhaps trying to make recommendations less woolly.
Thanks, Michael. Are there any other questions on this report at all? Okay, thanks, Michael. Thank you, Suzanne, and thank you for everybody else on that team for the work that you've done on this one. And we look forward to the results of the action plan. If we can move on to the Freedom to Speak Up Guardian report, please, for Rachel Claire Evans.
Thanks, Andy. So this is the Freedom to Speak Up report. And as I think everyone will know, we're at a fairly early stage in our new contract with the Guardian service. And you might remember that we were previously reported to the board to kind of wrap up our previous arrangements just as we were about to introduce the new Guardian service. And this paper brings us a bit more up to date. So the main body of the paper went to the Workforce Committee in May, and the feedback that we all felt was that the paper and the report could have been more granular about the information that was coming through and to help us to identify more themes. And we've gone back to the Guardian service to try and get that additional level of granularity. And given that that had come before this board meeting, we thought that it would be useful to incorporate that in the paper. But we will be looking at that in more detail at the next Workforce Committee. There are 3 points of clarification I wanted to bring out about the paper. So you'll see that the paper mentions that the numbers of issues that were raised are lower than this time last year. And that might beg the question of whether or not the profile of the Guardian service is high enough. What I would flag, and as has been mentioned to the board previously, is that our staff partnership team, who used to do our Freedom to Speak Up work, took quite a different approach to the one that the Guardian service takes. And they would get a number of their issues through some of the team meetings that they would go to, and they would add those into we're not quite comparing apples with apples when we look at the numbers, but going forward, we should be able to see whether or not the numbers are consistent and at the sort of levels that we would be expecting. And I have asked the Guardian service whether they think we've got the right sorts of levels of issues coming through, and they're fairly confident that these are the right sorts of levels that we should be expecting to see. The second point of clarification is around the fact that you'll see that this does break down by where the issues have been raised. And I had some concern to see that there were some directorates that hadn't raised any issues with the Guardian service. Again, worried that that might indicate a too low a profile. I'm pleased to report that nearly all directorates by now have raised issues of concern. The data that you've got in the paper there is up to March. So that's a good thing. And then the third point of clarification I wanted to make is around this new granular detail that we've included towards the end of the paper, where you can see a bit more detail about each of the issues that have been raised. And my sense, as I looked at that table, I found it very useful to see that it was bullying and where there were bullying and harassment issues. I found it useful to see where there was a discrimination and inequality issue. But where they've described the nature of the complaint as being systems and process, I found that a bit vague. It didn't help me to really understand what sort of issue was being raised. And I've raised that with them. And in the future, they'll give us a little bit more granularity. But what they've said is that what that's about is the kind of the inconsistent application of systems and processes, such that people perceive that there's unfairness, but they're going to clarify that going forward. So we've been with the Guardian service now for about 6 months. And there have been some teething difficulties, not in the way that they've handled the specific issues, which I think has gone fairly well, but in the way that they've kept us up to date about the themes coming through and specific issues of concern. So going forward, they're going to be including more of this granular detail and more of the themes, and I'm pretty confident that we'll be able to really get it on track so that we're getting the information out of them that we really need to help us tackle the specific areas of concern. And you'll see that they've identified 3 themes coming through to date. Now, they do want to really point out this is at a very early stage. They don't want us to attach too much to those 3 themes, but they are interesting, and I think they do resonate with some of the issues that we're already hearing through the BAME WebExes, for example, and through other routes. So one is about management style, and we're going to be looking in the action plan group about how we really train up our managers. There's something about managers potentially favouring team members of their own ethnicity, and that's going to be a specific focus within the action plan group too. And there are some themes around people feeling that resources are getting in the way of them providing the service that they want to provide. I've asked the Guardian service to come back with a bit more information on that point. Their preliminary feeling was that it was where services had been redesigned and commissioned slightly differently, and that people were harking back to a time when the service provision was perhaps slightly broader, but they're going to give us a bit more information on that in time for the Workforce Committee. The final point I wanted to raise was that they highlighted to me that the quality of the reports from our own internal investigations that they're seeing are far higher than they've seen in any other organisation. So I thought that was some really useful feedback, and my thanks to people like Jane and others who've been involved in those investigations. That's what I was going to say. Thanks.
Thank you, Rachel. Steve, James, you want to come in on that one?
Yeah, just a quick. I haven't turned my video on because I keep fading out. So it was a quick couple of points. One was, it is concerning that nearly 50% of the people who contacted the Guardian service did it because they don't think we would take any action or that they wouldn't be listened to. So I think there's an issue there. I mean, it's very early days, it's low numbers, but that concerns me. The other thing is, again, it's early days, and again, it's been difficult to contact people, but there needs to be a better relationship between the senior independent director, that's me, and this, because we have tried to contact each other and it's not worked so far. So I need to work harder and they need to work harder on making certain that there's a link between the two.
So just on those points, Steve, I completely agree with you on both of them. So it is concerning that people fear that we wouldn't follow up on issues or that we wouldn't take any action. I think we have a real opportunity with some of the issues coming through as part of the response to Black Lives Matter to demonstrate how we as an organisation really listen and act. I think there are some things that we can be doing around our culture, but the most important thing will be people seeing that we are open to feedback, that we listen to it and that we act on it. And when I was talking about the teething difficulties, Steve, around making sure how they're keeping us informed, I was specifically referring to the fact that I don't think they've been engaging you in quite the right way, and I don't think they've been engaging me in quite the right way either, but hopefully that will be fixed going forward.
Right, yeah, no, that's fine.
Okay, thanks very much. Any questions for Rachel on that? And if not, thanks very much indeed, Rachel. We now go to Azra for the charitable funds report, please. Azra, I think you're muted.
Press the button. I think, can you hear me now? Okay. So the charitable funds update is for the year 2019-20. We have consolidated a number of the accounts from 55 as at the end of the year to on the 1st of April, having had some input as well from the Charities Commission, to 25 funds at this moment in time. You'll see in the attached report it did refer to 27 funds. That's because 2 of the funds have now actually expended the funds on various different projects. The opening fund balance at the start of the year was 565 and the closing balance is £463,000. And since the last board meeting, we've established a new fund that was linked to COVID-19 and was a consolidation and a share of the funding that had come through from NHS Charities Together. So we effectively pay a £1,500 subscription fee to this, and that has engendered funds to the tune of 60,000 year to date. We are currently going through a set of actions to disperse those funds, meeting the needs of the NHS Charities Together requirements for those, and we are consolidating those through the executive team to make sure that there is equity for all of our staff groups. I'm not going to go through detail in regards to the attachment, given time and the assumption that everybody has already read the pack, but I'm happy to take any comments.
Everyone may have seen it, but Steve James has declared an interest with regards to the South London Special League, which has received monies from Oxleas, and what a superb organisation they are. Now, Azra, do you think we're making the best use of this money?
Is that in terms of disbursement of monies, or is that in terms of trying to generate additional funding? Because I think those are 2 different points.
Disbursement of the money.
So I think disbursement of the money, we've left it to fund holders where they have got the ability to be able to know the services, to be able to disperse that money. We've clearly had a period of time prior to, I think, last year where we hadn't really been dispersing the money as we're seeing it, but we're seeing a much greater uptake of individuals accessing the money and then spending it on the purposes for the funds. And certainly with the commitments that we have now made, there is a number of funds that I think we will be dispersing quite generally through at a much higher rate during the course of 2021. I think other than that, it is effectively down to the fund holders in terms of how we play that through. And what we have done is we have raised now at every single finance meeting the balance of funds that is available to that directorate to be able to access, just to make sure that people are aware of the funds that are available.
Okay. And Nina has also declared an interest in respect of Charity Commission role. Now, I suppose one of the things is around restricted funds, and I see that we've reduced the numbers of those. I wonder if there's anything more we can do on that. I thought your answer was very careful, Ezra, as it would be for an FD. I still wonder if we could not be doing more. We may have highlighted it to people, we may have pointed it out to them, but the point I've made for a period of time now is this money sits in accounts. It doesn't earn any interest. We pay to have it audited. And my personal view is I'd like to see it used. And I don't like money sitting there when we could be doing something with it. Any thoughts from yourself or Stephen Dilworth?
Yeah, I think I'm sure Andy and Joe will correct me if I'm wrong on this, that we did agree at a previous review within Business Committee that we would want a report at some time looking at the value, the benefit of the funds that we dispersed, because I don't think we've ever seen a report on that. So we're better at giving the money away. What I don't think we're so good at is making sure that that money is well used. So we'd like to know what's the outcome on whatever funds we've given away.
I think that's a really good point. Steve James?
Thanks. It's just, I think sometimes we get confused about what we might want to spend the money on. I think we do tend to talk about supporting the staff, which is obviously a legitimate use of that money, but there's also, we could spend some of it on, well, the South London football is an example, but we don't do enough of that. So there are, for relatively small amounts of money, we could really encourage community groups to do all sorts of things for people, patients and service users that we see. And we don't, there doesn't seem to be a sort of a strategy around that. So, we could spend, I don't know, half of it on staff and our own staff and half of it on community initiatives or something like that. It doesn't have to be half and half because some of it might be restricted. But we don't seed fund things that are in the interest of the patients that we see. And I think it's not a lot of money, but you could do a lot of good with some of that in community groups.
Yeah, I agree. That's a good point. Suzanne, do you want to come in?
Well, it's just a very quick one. I absolutely support both the comments from Steve and Steve. As a charity chair, one of the things that I find I sometimes have to remind my trustees is that we're under a positive duty to spend the money that we hold as a charity, because that money was donated to us in order to benefit our beneficiaries. And if we're not spending it in their interests, then we're not fulfilling our charitable purpose and our duties. So I think I support the notion of a strategy that ensures that we are appropriately spending the money in ways that achieve as good outcomes as possible for the local communities who have in many instances made the initial contributions.
Yeah, I think it's a really good point. And Joe rightly points out that we have put a fair bit of money into the Charlton Athletic Community Trust, which again is another superb organisation. I suppose the message I'd like to send back is, which we have said a number of times, a really proactive approach to spending this money. It shouldn't be sitting in our accounts. We ought to be doing something with it. Absolutely, Stephen Dilworth is right. We need to know it's being used for a good purpose. But with a proper business case coming in from these charities, we ought to be able to spend it. And Suzanne's point is absolutely right. And I think we actually have a duty to spend it. So we look forward to some spend on that. I know you've been extremely busy. You've been absolutely focused on everything else. But pre-COVID, we talked about this quite a lot. So post-COVID, we'd like to as well. Is there anything else from anybody else on ASRA's report?
Just finally, Andy, then to say that I will absolutely take that forward in terms of a set of actions and have another discussion probably at execs about how we can take that forward. And in regards to your question on restricted funds, that was the reason that we had involved the Charities Commission. So I think we've now reduced that to the level that we wouldn't be able to reduce it further in terms of consolidation, because there are strict rules that apply to some of the remaining restricted funds.
Thanks very much for that. I understand that now. Azra, I look for you to drive people on this one. You've told them about it. Now ask them what they're going to do about it. I'll be grateful for that. Thanks ever so much. Colleagues, I've been going for a little while now. I make it 12:19 according to mine. Shall we regroup at 12:29 after a 10-minute break, if that's okay? Thanks very much. I shall see you in 10 minutes. If we can now move to the next item on the agenda, item 11, which is the MSc and Performance and Quality Assurance Committee, please, MSc.
Thank you, Andy. I'm not going to go through everything in the paper. I will just assume that everybody's read it, so I'm just going to go through highlights. So we had a paper on the clinical Senate, and the terms of reference were given to us, and we recommended that they be approved. So in your pack, you will see the terms of reference which we've brought forward. And I believe we've discussed the Clinical Senate before and its role in scrutinising COVID-19 guidance and strengthening that guidance and then passing it through to the exec. So if we're all in agreement with that, just to approve those terms of reference. Other things we've discussed, pressure ulcers, we had a look at those. And there seems to be an upward trend. So we've discussed those over the last couple of months. However, we've given assurance that yes, there has been an increase in pressure ulcers due to end of life that has been seen in the community teams, and also a new type of tissue injury, which we believe is related to COVID. So we are keeping a close eye on that just to see hopefully levels come down, and if they are still high, how we're managing those. If we then move on, we've also seen an increase in restricted practices, which is a shame considering all the work that we have done over months and years to get down prone, increase supine, and just generally reduce restricted practices. We were given assurance that it was because of COVID and the scenarios that have arisen there in terms of anxiety amongst patients in our inpatient services. But again, we are closely monitoring that. We've asked for more data because we need to see more on a granular level exactly what was happening in our units. So we will be taking having a closer look at that in future at our next meeting. In terms of patient experience, we looked at the SNET. We've talked about SNET today and how, unfortunately, in that serious incident, it wasn't completed. But the data that we were presented with was actually during the COVID period, which is obviously after the incident that happened in February. SNET completions were being done, and the targets that we've set ourselves, 80% and 50% respectively, we are heading towards that. So that was really positive. And we commended the staff that even during these difficult times that they were being able to do that. So that was positive. In terms of our regulation in CQC, we have seen an increase in inquiries from the CQC, and we looked at those into details as to what they constituted, and it tended to be frequent complainers, so it was the same people over and over again, and then the restrictions that had been put into place on our wards because of COVID. So we didn't necessarily see a worrying pattern in terms of CQC inquiries. But again, that's something that we continue to be cited on and are monitoring on a month-by-month basis. And I think the only other point that I wanted to mention for the board was that there was, we are asking for approval in terms of CQC registration changes. So for administrative purposes, all our community services have now we're hoping for approval that they're now going to be put under Pinewood as an address. And apparently that will reduce our internal administrative burdens, but has no, doesn't affect quality at all or patient safety. And then also we were removing 2 regulated activities that were no longer required. So we're asking the board to approve those changes. And I think those were the main things that I wanted to bring out from our last 2 meetings since the last board. But I'm happy to take any questions.
Any questions for EMSC on that? And then the other question is to approve those changes to the CQC registration.
Sorry, Andy, it's Ian. Sorry, I've failed to be able to type in on the comments. I just wanted to just make a quick point about the completion of the SNet and that SI. It's just to say that the person was admitted with a completed SNet, but it wasn't then updated while they're on the ward. It's a small point, but I just wanted to kind of, I suppose it's illustrative of the fact that you have to kind of keep going back to these things.
Thanks very much, Ian, for that. So the question, colleagues, do we agree and approve that CQC registration change? Sorry, yes, agreed. Thank you for that.
Yes.
Any questions for EMSC at all on the report? If not, then we'll move on to Joe for Business Committee, please. Thank you, EMSC.
Yeah, again, if I take the same approach, I'm sure Azra might want to add something, but just to pick out a couple of the highlights, you can see that our COVID spend now is about 0.7 million per month. We had a bit of a catch up as we've sort of improved the way we identify spend in May. Of course, we've got arrangements in place at the moment, which mean that effectively NHS Central are ensuring we break even, so we're being reimbursed for extra costs. Agency spend, despite everything that's been going on, continues to be very low, which I think is very gratifying, actually. So temporary staffing is lower than it has been, which is very good news. That was in May. Just picking up on bids and tenders, it's not quite a bid or a tender, but I think as evidence of our continued good relationships with NHSE in terms of commissioning prisons work, we've been asked to take on a dialysis contract to provide a more local dialysis service, which it looks like it's going to be based in Greenwich. You can see some information in the covering note there. We're expecting that to come back to Business Committee this month because it was quite early days on that. But again, positive. Disappointing letter from NHSI, who basically have stopped work on doing anything to do with subsidiaries. So we wanted some permission to go ahead on some things to Wensley Close. This is a bit more in Suzanne's remit than mine. But unfortunately, we've had a letter, which I suspect every trust has had, basically saying they're not going to do any work to approve any transactions at this stage. A bit open-ended, unfortunately. And then the final big point really on page 128 of the bundle at the top. Clearly, we're in this process of top-up arrangements at the moment. That will come to an end. And Azra, I'm not sure if we formally heard when that will come to an end. At the moment, I think we're working probably on the basis that it won't be until the end of the year. But then we're expected to be faced with the efficiency challenge or cost-cutting challenge that we thought we were going to be faced with this year, and it's significant. And I think we were going to struggle to meet that challenge in a normal year. But with all the sort of things we're talking about in terms of coming back from COVID, maybe some changes in the services we're delivering, that is looking very tricky. So we had a bit of a verbal update on that. But given where we are, it's very difficult at the moment, I think, for the Trust to identify those big transformational programmes that will ensure that we achieve that target, albeit there's lots of good work going on to capitalise on some of the positives coming from the different ways of working. So they were the points I wanted to highlight. Azra, I don't know if you want to add to those.
Thanks, Joe. So I think just picking up on the SIP element and whereabouts we are with the block, the expectation is that we will continue with some block arrangements, but they will move to be something that, and in regards to the top-ups, that they will move from something that was a nationally derived, i.e. direct from NHS, i.e. to the Trust, to something that would actually follow through the ICS programme. We still haven't had confirmation of the arrangements from month 5 to month 12, but we have been told they're likely to be block and top-up. but the nature of that block and top up may change. And I think nationally there is already some concern about the level of spend that we saw nationally in the March, April, and to some degree the May period. So they are likely, I think, to start upping the agenda in regards to some of the transformational changes and some of the SIP requirements. And I will give a briefing, probably should be there, I would hope, by the time the next business committee arrives, given the fact that we run out of these arrangements at the end of July. Other than that, I think you'd picked up all of the main points from our meeting since the last board.
Thanks very much, Azra and Joe. Any questions at all on business committee? Thank you. We'll go on to infrastructure committee, please, and Suzanne.
Thank you, Andy. Just to draw attention to some of the key points in here. There was an extraordinary meeting of the Infrastructure Committee to approve the capital programme prior to submission by NHSI, and the board is asked to confirm the decision that we made. It's been through infrastructure and it's been through finance and it's gone through NHSI, so I'm hoping that the board will want to confirm it. At the same meeting, we talked about a couple of tenders for projects related to QMH. And I think one of the things that's perhaps just worth drawing to people's attention is that we did have a discussion at the meeting about whether it was right to go ahead with these two projects in light of some of the changes to the built environment that sort of post-COVID transformations might require. And we're assured by the estates team that these are still sensible projects to go ahead with. Moving down the other to the next meeting, we had quite a substantial agenda at the standard meeting, and I just want to pull out a couple of points from that. We very much supported the business case for a move to Office 365 on the basis that it would be a leap forward in terms of the quality of our informatics infrastructure and would really increase the resilience of our infrastructure in that area. At the time, we hadn't quite bottomed out how this was going to be paid for, but the view of the committee was that it ought to be possible to find a way of paying for it. So that has been subject to further discussion by the finance team. I should draw attention to the board to the Information Governance and Cybersecurity report. This is something that must be seen by and approved by the board. The one comment that I would want to make about it is that we had an interesting discussion at Infrastructure Committee about what was being learned, both from the serious incidents that we'd had to report to the ICO, but also from the lower level incidents. And importantly, some changes have already been put in place in response to those incidents. And there was a view that the move to Office 365 would actually really help with some of the lower level incidents, because it would enable people to work in a way that it would facilitate safe, as it were, sort of cyber safe working by avoiding some of the workarounds that sometimes arise when people are dealing with inflexible IT systems. We're discussing the QMH Theatres project in part 2, so I won't say anything about that now. And the only other thing to draw people's attention to was that in addition to the risks that were brought to our attention and noted by the committee, we have proposed some additional risks, one of which is intended to make sure that we spend some time with the ICS over the next year, really understanding what the ICS as a whole wants to do in terms of estates, so that we don't find ourselves kind of caught out at the last minute, having to go through a kind of trading process with other trusts, because we find that we've all got ambitious plans for our estates which can't be met out of the total sum that we have to play with.
Thank you, Suzanne. So the first question there is, do we approve the already submitted capital bid? Unanimously agreed by colleagues, as far as I can see on that one. Azra, you want to come in?
So it was picking up the point on 365. The finance team have gone away and had a look at that, and there should be a revised paper that's coming through back via Alison in regards to the finances. But it is just noting that it is an increase in revenue costs. So there needs to be some mitigation via the transformation that we're going to be doing in terms of digital first working that wouldn't be required in order to be able to pay for that. Otherwise, it would increase the £13.5 million CIP. That paper I should be finished reviewing today, so we should be able to take that back round the loop.
Okay, thanks very much for that. Alison, did you want to come in at all on that?
Yeah, I mean, I just wanted to comment. I think there are some mitigations in the business case around reduction in travel costs. I think we think that some of the reductions in travel costs as a result of digital ways of working can mitigate some of that gap. But I agree with Azra. We need to ensure that as an organisation we agree on how we're going to mitigate the rest of the gap.
I suppose the issue there is actually capturing the money, isn't it, Azra? I mean, we can talk about we'll make savings, but unless you take it out of somebody's budget, and actually capture it. I mean, obviously, obviously 365 is a great idea, but you got to be the guardian of the money, haven't you?
So that's the exact piece that I think we will probably need to have an exec conversation about, because we have gone. Ian and I recently went through the cost pressure list, and against the available funds and any other balances that we had available, we have given out the max. We maxed out that figure, and that was before we got the 365. So we need to take that back round the loop with the cost pressures we've already approved, and then the balance that's coming through here, and to just check with the directorates whether or not they want to do a budget or a run rate adjustment in regards to the travel expenses. But as I said, I think that's a conversation for the execs. We should be able to bring that back. The issue is going to be, obviously, we will make that decision prior to the next board meeting on account of the timeline that's associated with the 365 business case and going back to NHS Digital.
Okay, thanks very much. Matthew.
Hi, Andy. I mean, Azra, Ian, and a couple of us had a conversation about this week in terms of how we make the. If we think about it, we invest money in the running of the organisation on a couple of fronts. There's the staff cost, which is the single biggest cost, but then we invest a lot of other money on the infrastructure that allows us to deliver care, and that infrastructure includes physical buildings and equipment in them. It includes the digital infrastructure that we've really invested a lot in over the years, and thank goodness we have, because it's really come to the fore in the last 3 months. But then on top of that, there's all the expenses. There's both the expenses that we cover in terms of staff travelling to and from places of work, and then there's some of us will have noticed that my monthly petrol expenditure has dropped from 250 quid to about £40 in the last couple of months. And so there's money that staff spend that's a discretionary amount. It's also associated with where they travel to where they work. So there is a whole load of money that is spent into the infrastructure of delivering healthcare. Some of that is discretionary. Some of it could be reinvested in different ways, and some of it's essential if you're delivering inpatient services. And what we're really keen to do when we think about things like 365, we think about things like digital working, we think about home working, about staff who choose to work from home, and then we think about inpatient staff, and that whole spectrum of things. There is an Oxleas investment sum that we spend on all this stuff. And as we decide, for example, that we invest in 365, which I don't think this is a choice for us, I think it's a must-do investment. The choice is how we fund it. I'm keen that we look across that entire set of infrastructure expenditures and think about how we move things around to fund that. And, as Ian and I have had a conversation about setting up for the next couple of weeks a weekly session that Azra is going to chair, unless that's changed since we spoke earlier this week. But it is very much to look about how we embed the principles of transformation in a way that helps us with that financial envelope, but that's driven by the desire to do the right thing around delivering agile, effective services. And that's consistent with the strategy framework we've been working through our next step. But this is the right time for us to do it. I know everyone's a bit tired and worn down by what we've had to do over the last 3 months, but we've kind of got to double down on some of this change now, because if we don't, we'll see everyone slip back to the way they were. And I had a conversation with a friend at the weekend who works in financial services at the city, they've just given notice on 50% of their office space in Moorgate. And they're pulling out there of some leases they had through to 2029. And he said it's cut their annual office cost by 12 million quid at a stroke, because they've realised how much they can do from home. You know, when my family works for the government department, you know, he works part-time, he says they've been told that you know, within their department they're likely to go to 2 days a week for full-time staff in the office and 1 day a week for part-time staff. And these kind of things can be transformed into some real cost savings, but not just as a cut, as a reinvestment. It's essential we invest this stuff in the things that improve work for our staff and that improve the quality of services for our patients. And I think in the strategy that we bring to the board in September, I hope to capture that concept in addition to be able to show you this is what we're going to do. Because I agree with you, Andy, you save money by closing stuff or stopping doing stuff. You know, we need to have some real hard stakes in the ground around this.
Well done, Matthew. Thank you very much for that. Really good. Rachel, you want to comment?
Thank you. I just wanted, I agree with everything that Matthew's just said, and just to remind people that we have already started that process, but of course this gives us a much better opportunity now going forward. And within the paper for infrastructure, we are specifically asking the board if we can dispose of a couple of properties that we have already vacated. I think that needs board approval, so I just wanted to draw that out to make sure that everyone is in agreement with it.
Can you remind me where that is on that paper, please?
Sure. It's at the bottom of the recommendation, so approving disposal of Murchison Avenue and Upton Centre in this financial year, and it's further up. It's on the second page of the document. We've been holding several properties actually for some time, but we think, despite where we are in terms of COVID, we've taken advice about the property market, and in terms of these types of properties, we're advised that it's as good a time as any to dispose of them, and the Infrastructure Committee have recommended that we proceed with those.
So this is a recommendation from the Infrastructure Committee, and Suzanne, you're recommending this, and from the business, audit and ASRA perspective, everybody happy? Yeah, I have. So therefore we're asked to agree, colleagues. I see a round of nods. That is agreement. Thank you very much indeed for that. Thank you, Rachel. Is there any, sorry.
Perhaps, if I could just draw attention to one last thing, because it is consistent with what Matthew has said, and I didn't highlight this part of our discussion, but Alison and Rachel have been thinking very actively around how to approach estates and the IT infrastructure post-COVID, and we'll be bringing a paper to the next Infrastructure Committee. It sounds as though, from what Matthew has said, that the thinking that they're doing is also going to be a wider executive piece, and I'll look forward to receiving that and supporting the forward progress.
Yeah, thanks very much. There's clearly an awful lot of good thinking going on, and we look forward to that in September. If we're done in infrastructure, thank you very much, Suzanne and Ezra. And we're going to workforce, please, Nina.
Thanks, Andy. I was nodding furiously to everything that Matthew was saying, and I think it's important to capitalise on a window of opportunity in practical terms, but also in mindset terms, which is, I think, the headspace that people are in at the moment and maybe lost all too quickly. On the Workforce Committee, I'm going to take the paper as read. I'll just focus on the key aspects of our meeting. From a health and safety perspective, we noted that we are taking a cautious approach in terms of reporting cases to the Health and Safety Executive, and we noted that there is no suggestion that any errors by us have led to people contracting COVID at work. We also noted a non-COVID incident at the Bracton that involved a member of staff being assaulted by a patient. And there will be further discussion of that when there is more information available at the next committee meeting. On safe staffing, we noted changes in how we're overseeing safe staffing from a pandemic perspective, and changes in student nurse training that are enabling students to assist during the pandemic. I'm not going to cover the freedom to speak up point, which Rachel Claire Evans covered in a lot of detail in the earlier item. On race pay gap, we noted the analysis of the Trust's position this year is significantly improved on the previous year. So BAME staff members currently earn just over 2% more than white staff, whereas this time last year, the data showed that BAME staff were earning just over 3% less. However, there is data that suggests many staff may actually be staying at the same grade for longer, and we've established a need to do more work to understand whether this is because of a lack of opportunity or an unwillingness to actually progress, and so that the actions that are taken are actually tailored and appropriate. In terms of broader discussion areas, we went over some of the extensive activity that has been underway and that many of us are aware of from a COVID-19 perspective, with a particular focus on BAME. I'm not going to go over that, just to say that I've been part of those WebEx discussions, which have been incredibly insightful. We've heard from Rachel previously on the staff risk assessment and the actions that have been taken as a result of that, as we have from Iffy on the letter that he has sent out to staff some time ago. We also noted, we talk often about the kind of list of never agains, the things that we don't want to go back to doing. And I think we spent some time talking about the improvements which have arisen in workforce practices during lockdown. And these are listed in the paper. Nothing more from me, Andy.
Thanks very much indeed, Nina. Any questions for Nina at all, please?
Can't hear you, Andy.
Yes, yeah, user error, as my wife would say. Now, I was saying, any more questions for Nina? And thank you very much. There's an awful lot on that agenda right now on infrastructure, on the workforce committee. So thanks for everything that your team are doing on that. If we can move on now to audit and risk, please, Stephen.
Thanks, Andy. Two main things that we covered off in our recent meetings. First of all, the annual report and accounts, plus the findings from our auditors. And secondly, the internal audit opinion over the last year. First of all, on the annual report and accounts, thanks to everyone involved, because obviously putting together all that amount of material, most people working remotely, including our auditors, has been a bit of a challenge. The very good news is that the accounts are unmodified. There were some challenging areas, which I'm just going to touch on now. First of all, around valuations. If anyone wants the detail on this, I mean, we had two meetings on the annual report and accounts, 20th of May, 17th of June. And on the bundle for the board papers, page 266 and page 271, you will find the detailed minutes of the discussions on the valuations. Basically, our advisors, Montague Evans, had carried out their surveys in December with a reporting date of March 2020, which is quite correct. So there just needed to be some discussion about whether their valuation figures still held up at the end of the year. And they did make the point that in their assessments, they allow for a plus or minus 5% in their valuation figure. Grant Thornton and ourselves and Montague Evans came to a form of wording that satisfied everybody. The good thing to note is that although residential house prices aren't doing very well, as has already been touched on earlier in your conversations, development values are actually holding up very well. So that does play into this discussion about valuations on our own properties. And we've got about £143 million worth of net book value for what it's worth. So that was quite a good detailed discussion. And at the end of the day, everyone was happy with the text that's been entered into the accounts. Most importantly, that the auditors were very happy with it. The second area of challenge was around journal entries, where the auditors commented on the authorization process. And actually, this probably caused more concern amongst the three non-executives on audit and risk rather than it did the auditors. And we were a bit concerned as to whether this was a significant weakness in our procedure. In fact, both for ASRA, she may want to comment on this, and for the auditors, the existing controls are pretty good, but there was room for some improvement. And Grant Thornton was of the opinion that it wasn't a significant matter and that action was being taken. And there were already controls in place which would stop any major abuse of the system. As I say, Azra may want to come back onto that a little bit later. So that all ended up with unmodified accounts, which is great news. The second thing is just to comment on the internal audit opinion from KPMG. They have assessed us as having significant, or given us a significant assurance with minor opportunities over the year. All our reports were in the what they RAG rate as yellow and green areas, so that was all good. There were some outstanding recommendations, but none of those were of significance. So again, KPMG were quite happy with how we'd handled them and the progress we were making. The only other thing I would mention, which we have commented on before, from a non-executive point of view, we felt that the terms of reference for some of the internal audit reports need a greater input from NEDs. I think we'll all remember that probably that was particularly applicable on the Section 136 reports earlier on in the year. So we're just adjusting that process so that we can provide that input, and I think that'll be a much better system, and you know, it will be better for the board on a broad perspective. So that's all the comments from me.
Thanks, Stephen. Azra?
Just come in on the journal element then. So I was actually grateful to the external auditors for picking this out, and just so that people understand, it was effectively, there had been a process, and there is currently a process in place where individuals could put in a journal and effectively sign off their own journal. That's not normal. You would normally have a dual authorization process. So once that was identified by external audit, I did a deep dive into the mitigating controls and also had a conversation with the relevant individuals within the department. I'm confident that we actually do have mitigating controls in place. However, we have put in a recommendation, and it's been agreed that somebody who definitely does not put in the journals will be reviewing them, and that will happen on a monthly basis. We're also this year going to be doing a new version of our general ledger, and I've asked, as part and parcel of that, we can try and bring in the dual authorization, which basically means that instead of a manual check after the end of the month, you actually literally could not put a journal into the ledger without somebody else that is independent reviewing that off. So I will progress that through, and I'll take that back through the audit committee once we actually have those positions in place.
Thanks, Azra. I thought it was a really interesting and vigorous discussion on that issue at audit. So I'd like to thank you, Azra, and your team for the huge amount of work that went in to put everything together at the end of the year. Not forgetting Sally and all the work that she was putting into the end of year report as well. And to you, Stephen, and the other NEDs involved for you know, a lot of work that goes into getting this right at the end of the year, and a very, very satisfactory outcome. So thanks very much indeed for that. If there's nothing more on audit from anybody else, we'll move on to the board visit reports. Obviously, everyone has read them, but what I'd encourage colleagues to do is highlight any issues they want to draw to the attention of the board. And if we start with the first one, that will be Nina and Greenwich Community Mental Health Teams, please.
This was a fascinating WebEx that we had. There were 3 points that I wanted to highlight. A number of people on the call drew out how they've been able to really, with the benefit of technology as a facilitator, enabler, that they've been able to really champion a family-focused agenda. And there was a really powerful example of somebody who was able to dial in a family member from Uganda, which would have just been impossible to do in a practical setting. That same ability of technology to enable multidisciplinary teams to come together, but outside of medicine. So with, for example, the police, with housing, it was important that the relationships were already there, but tech has enabled those people to be around the table having conversations at the right time. The last observation was around how the absence of bureaucracy combined with a real desire to progress and advance things digitally while keeping people safe, while focused on providing a good service, had just enabled things to become possible that people not so long ago would have thought. Sorry, that people not so long ago would have found impossible. So I just think it really is important that we take the time to pause before we refreeze into our kind of new ways of doing things or old ways of doing things. Nothing more to add on that, Andy.
Thanks very much indeed, Nina. That sounds like a really, really interesting one. I think the next one, Rachel, please.
Thanks, Andy. So we had Helen Jones and I had 3 successive visits to Greenwich community teams on the same day. So I put them all in the same report. So overall, there was generally a sense of people feeling that things had stabilised quite a lot after a slightly bumpy start, as you might expect with COVID, and people really feeling quite settled into a new rhythm and way of doing things. And also people very clear that they wouldn't want to go back to previous ways of operating. And I think we're seeing that consistently across a number of teams, but a real sense that whilst there were some things that they were missing, there were a number of things that were much better about how they were working now than how they were working previously. So that was quite encouraging. 2 things just to highlight, I suppose, I took away from my own reflections. One was that, wholly understandably, and very sadly, in teams where patients had died, as in ECH, there was really still a very strong sense of teams feeling very shaken up by that. And I've been very grateful for discussions with people in Michael's team about what the right point is and how we best support people who've gone through that sort of grieving process. And the other point that came through, which is going to be really important for us as we open up more services and as perhaps some of our shielders might start to come back to work, is that real sense of anxiety that some people feel who've been working pretty much exclusively from home for a period of months, their anxiety about coming back into a work setting and how we help them to acclimatise to that way of working. And Nina and I have had some good conversations about this, but I think it's going to need some structured supports to help people back when it's the right thing for them to be coming back into the office. So that was just my water to the walls. Those are just my high level reflections. Thanks, Andy.
Yeah, thanks very much indeed for that, Rachel. Alison, you wanted to come in?
I just wanted to pick up on the points that Nina raised around digital. I think in all the services there are some really good examples of how people are using digital means to communicate with patients in innovative ways. And I think we need to ensure that we continue to advertise and showcase that across the trust so that teams learn from each other. So we're doing that in some part with the trust-wide webinars that are taking place with directorates at the moment. We're also planning, working with Sally's team in comms to get that down on paper or digitally so that we can advertise that through newsletters across the trust as well. So we continue to learn and people can take the good practice that's happening in pockets in the organisation and use it in their teams too.
Thanks, Alison. Steve James.
Sorry, I didn't mean to jump in front of Joe because I know we haven't finished the board minutes. My visit to, I just wanted to say I visited Holbrook through WebEx, who were very, I mean, obviously extremely shaken given their experience, but incredibly tight, well-led team who had acknowledged that they'd been through a difficult time, felt well supported, and I think after a little bit of a break, are ready for the challenge again. It was very impressive to see both the individuals, but also how they were led. So I was really reassured after the session because they could have been really very battered, and clearly they.
I've lost Steve. Has everybody else lost Steve? Yeah. I think we got the point that Steve was making there. You can come back to it if we get him back. If we move on to the next one, Jane, please.
Thank you. We had a really well attended WebEx with Greenwich IAC, possibly one of the largest WebExes I've been involved in. Really engaged team. Just a couple of points to feedback on. Was firstly, at the time that we did this meeting with them, the team was still trying to get that work-life balance. That working from home is a very lonely period of time, and how they were working through and exploring different ways of getting support for each other was really important. The other really important areas that they wanted the board to know about was firstly, whilst they embraced the digital working, they were able to very clearly articulate where there was a potential for further widening of inequalities, particularly for vulnerable groups. And they gave lots of different examples which are listed within the paper. And they were really concerned that going forward, that we didn't adopt a blanket approach to digital working, and that we made sure that we weren't disadvantaging some of our most vulnerable people anymore. And thirdly, they really wanted to make sure that the board was fully cited on the concerns they had around BME communities themselves and their BAME staff, their BAME families and their patients and service users, and to make sure that we were taking it forward and proactively addressing it, which I believe we've covered in other papers and updates during the meeting already.
Can I just add that it was that feedback that really helped us to develop our individual staff risk assessments to make sure that it took account of the wider piece that people might be operating with. And I don't think if it wasn't for that visit, we would have necessarily positioned it in that way.
Thank you so much. That's obviously an extremely valuable one. Joe, you've been busy.
Yeah, been trying to get around the teams. Just a couple of things to highlight. So firstly, there is concern quite rightly about backlogs growing, and Ian mentioned that quite a few of the backlogs he was concerned about were occurring in the CYP division. So I think we really need to sort of pull through what we think those backlogs are looking like. So particularly things like ASD. There's particular issues around face-to-face medicals and assessments for looked after children, which include asylum seekers, and I think there hasn't really been a halt in asylum seekers coming in. I think completely the opposite. The other thing to mention is demand on services, and particularly that and the earlier point in my note, which is about seeing young people in ED at QEH largely. It seems to be less problems at the PRU. So we've had the whole issue of what is the right solution in a sort of, a non-COVID area for seeing them. And that went through quite a few iterations, and the team, the crisis CAMS team, had felt that they hadn't really been consulted on that journey. We've now got a physical solution that I think is fit for purpose, but where thoughts are now going, and I think there have been quite a few meetings between the CYP team, RBG and LGT, is really, it's not just a physical solution, it's a pathway for young people who, a number of whom are suffering sort of enhanced issues, I think, because of lockdown, lack of schooling and such like, and the social elements of the issues are very much coming to the fore. So we're hoping that we can really engage RBG in particular on that. Positive feedback so far. The other thing I just wanted to mention was the leadership team in CYP is quite new. Lisa Thompson was appointed, I guess, at the beginning of the year, and Sabitha a little bit before then. And I really am quite impressed with what they're doing and the way that they're interacting with their team. So just wanted to sort of feed that back as well.
Thanks very much indeed, Joe. That's really helpful. A lot of good visits there. I think that's it on those. If we now go on to Sally and the Council of Governors update.
Thank you. So this summarises the activities with the Council of Governors since the last board meeting. And I'm pleased to say we've really been able to maintain our contact with governors and continue having Council of Governor meetings during this time, and have started our visits virtually for governors to services, getting that back and running. And then this just with notes for the board, our annual members meeting that we're looking to hold later in the year, later than usual, but this still fits within our constitution so that we'll be able to present our annual report to members. So that's a summary of the paper. Are there any questions?
I think a thanks to our governors for continuing to attend board subcommittees, and also to Richard for your support throughout all the time, but particularly during COVID. And it's been great to have you on board and have your views and insights on things. Any observations at all on Sally's paper? If not, we'll move to any other business. I haven't been notified of any, but that doesn't mean you can't. We're going to have to wave or put something on the screen. If not, then we'll stop there. Thanks very much indeed, everybody. It's a huge amount of work has been going on from the executive and from the staff at Oxleas at every level. A really outstanding performance, I think, from everybody. And I think on behalf of the NEDs, and I'm sure on behalf of the governors, we'd like to thank you all for everything that you and your teams are doing. I mean, it really has been a hugely heartwarming and superb performance from you all. Thank you so much indeed. We're going to move to, that will bring the end